Principles of Antimicrobial Prescribing. Using antimicrobials wisely requires a systematic and principled approach to their use. In this module, we will review the principles of antimicrobial prescribing, laying the foundation for the remainder of this course. To make this course most useful to practicing clinicians, we'll be exploring each topic within the context of the clinician-patient encounter. Let's begin this module with a case. You are evaluating a 38-year-old woman who presents to your hospital with a 2-day history of fever, chills, left flank pain, and dysuria. Her physical examination is remarkable for the presence of fever, tachycardia, hypotension, and costovertebral angle tenderness bilaterally. Urinalysis reveals pyuria, and urine and blood cultures are obtained and sent to the laboratory for identification and antimicrobial susceptibility testing. At this point, you recognize the signs of septic shock, and given her clinical presentation, think acute pyelonephritis may be the source. You resuscitate this patient with intravenous fluids, and know you should start antimicrobials as soon as possible. But what empiric antibacterial regimen would be the best choice for this patient? In general, antimicrobial use is commonly categorized as prophylactic, empiric, or definitive. Antimicrobials are used prophylactically to prevent infection. Examples of this include antimicrobials used to prevent opportunistic infections in immunocompromised patients, and those administered prior to surgery to prevent surgical site infections. Antimicrobial prophylaxis should only be used when supported by evidence-based guidelines, including, for example, the WHO surgical prophylaxis guidelines shown here. Antimicrobials are used empirically when infection is suspected before microbiologic data to support this diagnosis are available. Much of antimicrobial use in both the inpatient and outpatient setting falls into the empiric category. Antimicrobial therapy is considered definitive, also called targeted, when it is specifically directed at the pathogen or pathogens as revealed by microbiological studies, including the results of susceptibility testing. At this stage in the case, you've determined that the initiation of empiric antimicrobial therapy is indicated for your patient. Furthermore, the first dose should be rapidly initiated, preferably within an hour of presentation, given the presence of septic shock. You must now determine the most effective empiric therapy for your patient and must consider the optimal drug, dose, dosing interval, and route of administration. Several patient and epidemiologic factors inform this choice that we will examine throughout this course. Broadly, these factors include the severity of patient's presentation, the likely source of infection and likely pathogens, the likelihood of an infection due to a drug-resistant organism, additional patient characteristics that modify your choice, and the timing of administration of antimicrobials in relationship to obtaining cultures. So first, how severe is this patient's condition? Critically ill patients require quick decision-making and timely administration of potentially life-saving antimicrobials. For those in septic shock, delayed antimicrobials are associated with increased mortality. Critically ill patients also require rapid achievement of adequate serum and end-organ drug levels, which determines the route by which you prescribe antimicrobials. Critically ill patients may also require an empiric antimicrobial regimen with an expanded spectrum of activity to include coverage against relevant resistant organisms. Because the margin of error is small in these patients, treating with a limited or narrow spectrum of antimicrobial activity up front could result in mortality or significant morbidity. However, in stable outpatients, this is often not the case, and an empiric narrow-spectrum antimicrobial may be more appropriate. Next, what is the likely source of this infection, and what are the likely pathogens? Answering these questions helps clinicians determine the necessary spectrum of antibacterial therapy, as well as if there is a removable or drainable focus of infection, such as an abscess, that would facilitate clinical cure. This is often referred to as source control. Clinicians use clinical presentation, including history and physical exam, as well as laboratory and radiographic evidence if indicated and available, to make this determination. Consider, for example, a patient with fever and abdominal pain who is found to have intra-abdominal abscess on imaging. Intra-abdominal abscesses are commonly caused by enteric pathogens and require early drainage in order to assure clinical cure. Next, how likely is this infection due to a drug-resistant organism? The spectrum of antibacterial therapy you choose is also driven by the answer to this question. For example, if your patient has received other antimicrobials for the same or different reasons within the last several months, she may be at risk of an infection due to a drug-resistant organism. You may also have local surveillance or cumulative antimicrobial susceptibility data that can provide guidance on the prevalence of drug-resistant organisms in your population. Next, what additional patient characteristics must be considered? Many host factors influence your empiric antimicrobial choice. Prior to prescribing antimicrobials, clinicians must assess the patient's history of drug allergies, particularly those that are life-threatening, such as anaphylaxis. The risk versus benefit of some antimicrobials must also be considered in patients with renal or hepatic dysfunction. For example, aminoglycosides should be used with caution in patients with renal dysfunction. Drug penetration, metabolism, and excretion parameters dictate appropriate dosing intervals for many antimicrobials. And finally, do I need to obtain cultures prior to starting empiric antimicrobials? In many cases, obtaining cultures after antimicrobials are started reduces their sensitivity. Thus, when indicated, it's important to obtain cultures prior to starting antimicrobials if the patient's clinical condition allows. In immediately life-threatening infections, however, treatment initiation should not be delayed for the purpose of obtaining, for example, a sputum sample. Blood cultures, however, should ideally be obtained before antibiotic therapy is started. Let's return to our case and discuss these questions. First, severity. You've already determined this patient has evidence of septic shock, making the timely administration of intravenous antimicrobials imperative. Next, what is the likely source? Given the patient's presentation, including symptoms and physical exam findings, you suspect pyelonephritis as the source of her infection. The presence of pyuria also supports this theory. The most common uropathogens are enteric gram-negative rods, with E. coli implicated in the vast majority of infections. Your empiric regimen must, at a minimum, provide adequate coverage for this organism. We'll discuss urinary tract infections in more detail in a subsequent module. Next, how likely is the infection due to a drug-resistant organism? In many parts of the world, E. coli is increasingly resistant to antibiotics, such as trimethoprim sulfamethoxazole, also called cotrimoxazole, commonly used to treat lower urinary tract infections. Appropriately constructed local cumulative antibiograms can provide insight regarding the prevalence of E. coli's resistance to commonly used antibiotics in your community. In this case, a cumulative antibiogram would compile all E. coli isolates from urine cultures over a period of time, for example 1 year, and would describe the proportion of isolates that were resistant to specific drugs. This can assist in making appropriate empiric therapy decisions. Here's an example of a cumulative antibiogram with each column showing the proportion of isolates that were susceptible to a given drug. For example, in this antibiogram, 70% of E. coli isolates that were grown in urine cultures were susceptible to trimethoprim sulfamethoxazole. It's important to note that cumulative antibiograms must include a sufficient number of isolates to provide valid insight regarding the prevalence of resistance in a population. In this example, over 4,000 E. coli isolates contributed data to this table. Next, what patient characteristics should be considered? Your patient reports no history of allergies to antimicrobials. Her kidney function is normal, according to her admission laboratory findings. Since you suspect pyelonephritis and secondary sepsis, you must select an antimicrobial that will achieve adequate drug levels, not only in urine, but also in blood and renal parenchymal tissue, since the patient may be bacteremic. Finally, do I need to obtain cultures prior to starting empiric antimicrobials? Since this presentation is consistent with sepsis, both blood and urine cultures are indicated and have been collected according to local standard operating procedures, using aseptic technique to avoid contamination. Clinicians can also refer to the WHO Best Practices document for obtaining blood cultures, shown here. In this case, imagine that a local cumulative antibiogram for your institution is not available. However, you do have access to local guidelines. Local guidelines will recommend different empiric antimicrobial coverage based upon the likelihood of resistance, based again on local data. For example, in a low-resistance setting, many narrow-spectrum agents, like first-generation cephalosporins, may provide reasonable empiric coverage for relatively stable patients. However, in high-resistance setting, expanded spectrum coverage may be more appropriate empiric choice. Local guidelines may also take into account local drug availability or institutional formularies. In this case, imagine you're practicing in a high-resistance setting, and imagine this patient was started empirically on an intravenous third-generation cephalosporin according to evidence-based local guidelines. In this module, we reviewed the principles of antimicrobial therapy with special focus on empiric antimicrobial use. In the next segment, we will discuss how empiric antibiotics should be readdressed to ensure continued appropriateness as new information becomes available.